Welcome back to EASD TV. Now, there was a very, very interesting session, old and new cell therapy. And I'm going to present the old and the new. And I'm afraid you fall under the old category. James Shaw from Newcastle University, and our newbies, as it were, Timothy Kieffer from the University of British Columbia, but also previously or currently Chief Scientific Officer of Fractal Health.
Currently, correct.
Currently. Glad we've got that clear. And Trevor Reichman from the University of Toronto, and you are also in the new camp.
Thank you. Thank you.
So let's start off with you, James. Tell us about the, if I may call them, the old approaches, or the old cells, I should say, rather.
Okay. Well, these old cells are established in clinical practice, often not so well known to people with who are managing diabetes, usually for renal failure with a pancreas transplant to completely normalize glucose levels in type 1 diabetes. And now also established as proven care is to take islets, the small clusters of cells that make insulin, and transplant those. So we have very successful old cells, but at the moment, immunosuppression, with its risks, means that it can only be for a small number of recipients.
Okay, so take us on to the newer bits then.
So the newer cells basically are stem cell derived. In the past, as James mentioned, the cell therapies were proven, but they required deceased donors. And that's always been one of the limiting things, is to have good quality donors. So that's in addition to immunosuppression.
And good quality dead donors. Good quality dead donors.
Yes, yeah. So that's always been, in addition to immunosuppression, was always one of the big limiting things. And of course, with stem cells, this sort of gives us an unlimited supply of cells that ultimately can be transplanted. And these cells, basically, over a course of about 5 weeks, are coaxed into being insulin-producing cells, or actually they're functioning islets. So not only do they make insulin, but they make all of the other hormones that a normal islet would make.
And are those scalable? In other words, you can produce enough?
As many as you want, yes. So the stem cells is essentially, self-replicating. So it can replicate as many times. These cells have been in existence for quite some time, the original cells.
And then you can ship them out to? Yeah.
So you're able to basically, through a very defined protocol, produce very reproducible product. And these can be shipped to anywhere in the world.
And here we're talking about cure.
Yes, yeah. So in the recent trial by Vertex, which was the 880 trial, there's now been 17 patients that have been enrolled. The 4 patients that have reached the 1-year mark essentially have been cured. So they are completely insulin independent, have basically a normal glucose control, and have a hemoglobin A1C that's within range.
And how do we know, really, when they've succeeded? That might sound a silly question to ask, but, is it for 5 years, is it 10 years? And how do we judge success?
It's not a silly question. In fact, it was the subject of my talk today. Well, we can tell if they're working by measuring insulin, C-peptide. But are they doing a good job is tougher. So we're looking at the usual measures, looking at HbA1c, looking at freedom from hypoglycemia, ultimately freedom from insulin, and then ultimately freedom from diabetes. But to know that it's doing a good job, we have to consider the burden of the therapy. If it requires immunosuppression, can it be delivered? Does it require very diligent monitoring for the rest of that person's life? So you asked the question about time. Initially, we're very fortunate, I think, that we can do some measures of function very quickly after transplant, certainly conventional transplants. And with that 1-month measure, you have a very good steer on how well the cells will work. Now, whether they work for 5 years, we've certainly shown with conventional transplants you'd expect function at 5 years. And we hope, and beginning to get evidence, that 5 years good function is enough to prevent complications. So the mark of success, I think it is that balance between how dangerous is it. If it's safe and easy to deliver, then the mark of success may be 2 years off insulin. Obviously, we're all looking for permanent freedom from insulin, but that's what the work's
And
aiming
the people
for.
receiving these will have immunosuppression?
Yes,
Yeah.
currently.
Okay, now let's go to our really new therapies. Tell us a bit about what you've been doing.
Sure. So just to follow up with some of the questions you already asked about duration and are we there, I guess I feel the bar is higher. I wouldn't say we've got a cure when you have patients on chronic immunosuppression, because if they stop taking that immunosuppression, the cells are wiped out, they're back to type 1 diabetes. So they're essentially trading insulin therapy for immunosuppression. And I think the next generation will be a cell therapy without immunosuppression. That's what we're working towards. And so that involves approaches to encapsulate the cells, finding other places to implant them, and genetically modifying them. So in Vancouver, for example, we have patients walking around now who have cells that have been genetically modified before coaxing them into the insulin-producing cells so that they can evade immune attack. Those patients are not on chronic immunosuppression. So ultimately, a path like that, I think, could get us to the point where we will have a cure. And I will say that in Edmonton, where they have the longest history of the islet transplant success, they've had patients more than 2 decades now off insulin. And I think it's reasonable to predict we'll see that with stem cell-derived islets as well.
So do you see yourself as a way station, a kind of on the way to something else?
I think so. I think this is really only the beginning of many more therapies. I think this was really a proof of concept in that that you could generate these insulin-producing cells or functional islets from stem cells, but it's really only the beginning. There's many modifications just to the initial protocol that can probably be done that will produce even better cells, and as mentioned, that's only the beginning of being able to genetically modify them to make them even better.
And actually that point about how long is very important in terms of regulators and take up by government, because you need to have some measure of how long this might last before you agree to a price and for reimbursement. And the price is also a huge driver of people doing companies. Or have I got that wrong?
Yeah, there's been a lot of discussion about that, and some of the most interesting models I've heard are saying pay for success. So first of all, as you heard, this is a truly unlimited supply of cells. So if it worked for, say, 3 years, there's no reason you couldn't implant more. We're talking about a teaspoon of cells and a very rapid procedure. So maybe healthcare providers need to change their model and say, okay, we'll pay you as long as the patient's insulin-free. If they need another dose, you're going to give them another dose. So perhaps that's the approach we need to take. But again, I do believe that based on the islet cell field, there's no reason to think our stem cell-derived islets, which are healthier, they haven't come from a deceased donor, they haven't been extracted from the pancreas, they should last just as long, if not longer.
And where else are you going with this research?
I think, I tell my trainees in the lab, we're only limited now by our imagination with the power of stem cells and gene engineering. So I think we can endow the cells with all kinds of designer features. There's no reason we can't be going after obesity, type 2 diabetes. We're thinking beyond type 1 diabetes now.
And it's interesting because you've got all these incretin-based therapies now, and they've got huge success, and they seem to be having all sorts of benefits way beyond glycemic control. And is that lessening the desire for people to have stem cell transplants?
I think we'd love to believe that these therapies may have a role in type 1 diabetes, and I'm sure they do in terms of stabilizing control. The big question is, can we regenerate a person's beta cells in their own pancreas once they've stopped making insulin? And at the moment, that hasn't been possible. It's fine in animal models, but to have beta cells that will regenerate and proliferate really hasn't been possible. So it may be that the cell therapy is just a way station, and eventually we want to be undertaking these manipulations in people with within their own pancreas, the drugs are really, really useful, but they don't regenerate beta cells. And we need beta cell regeneration. We need more beta cells for type 1 diabetes, and that has to be through cell therapy. And I agree with both the speakers. I think if you get a good engraftment, there's no reason that these cells won't work for a very long time, particularly if you can have a more gentle, ongoing management of them.
I just want to add that the incretin therapies are truly remarkable. GLP-1 can cause profound weight loss and, as you alluded to, improvements in metabolism, but only as long as you keep taking them.
Yeah.
As soon as you stop, you lose all the metabolic benefits, very quickly regain weight. So it's Blue Cross Blue Shield in the US, a major healthcare insurance provider, has just released real-world data showing 30% stop taking them in the first month, about half within 3 months. Nobody wants to continue to take chronic medication. And so, my other hat working at Fractal Health is a gene therapy for GLP-1. The concept is a one and done. It's very similar to the cell therapy. Take the control out of the patient, put it back in their body, and have normal regulated hormone production. I think that's where the field of medicine is going to go.
It's fascinating. It's a really fascinating area. Final words to you.
Well, it's a very exciting time. I guess my final word to diabetologists and the whole community looking after people with diabetes, indeed people with diabetes, is please embrace these technologies, learn about them, become engaged, speak to people that are delivering these type of therapies, because now we need the interest to convert to trials and to outcomes.
Fabulous. Well, you heard them say it. Diabetologists, these stem cell gene therapies, their time is coming. They are in the spotlight. Have a look at them. That's all from EASD for the moment. Thank you so much for being here on my sofa.
Thank you.
Thanks
Bye
for
for
having
now.
me.
Thank you very much.